Om Swastiastu, Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya. Greeting of peace to all of us. Welcome one, welcome all to this auspicious call, where knowledge reigns supreme and wisdom stand tall. With heart open wide and minds ready to be soared. Let's embark together to learn and explore. In the realm of static anesthesia, we convene the delve into depths where insight gleam from dawn till dusk in this virtual space. Let's unravel mystery with grace and embrace. First of all, allow me to introduce myself. I'm Rianda, who will be hosting this special occasion in welcoming the activity of the third Indonesia Scientific Meeting on Obstetric Anesthesia and Critical Care, which we held on 1st until 6 July 2024 at the Jimbaran Convention Center, Intercontinental Hotel, Bali, Indonesia. The committee has collaborated with the Department of Anesthesiology and Intensive Care of Prof. Dr. Ngurah General Hospital and Faculty of Medicine and Dayana University, Bali, to organize 7 webinar series activities and 1 guest lecture which can be followed online through the Bali Anesthesia YouTube channel. Before we begin this guest lecture, allow me on behalf of the entire committee to express our warmest greeting to all of us. And please let me to send our deepest gratitude to our sponsor, PT Active Scientific, who have support this guest lecture. On this occasion, we have to speaker and 1 moderator to guide with us and Dr. And we have as a guest presenter. Thank you for taking the time to participate to the with question to the as many questions as possible. We are pleased to inform you that we also offer a dedicated WhatsApp group for participants on of information and update the group. At the end of the guest lecture, the committee has also provided an attendance link in the participant can use to obtain a certificate for this guest lecture. To achieve the certificate, the participants are required to create a Pelataran Sehat account, but for now, the website is under maintenance. The website can be accessed on 12 May 2024. Before we start our discussion, let us invite Pelataran Sehat Committee to introduce themselves. Please, Dr. Tommy to introduce.
Baik, saya akan berbicara dalam bahasa. Selamat siang, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita sekalian. Om Swastiastu, Namo Buddhaya, salam kebajikan dan shalom. Yang terhormat seluruh peserta webinar dan juga panitia yang sudah mempersiapkan kami untuk menjelaskan tentang pelataran sehat. Baik Bapak Ibu yang sudah tergabung di dalam webinar kita pada sore hari ini, sedikit kami akan menceritakan ataupun menjelaskan tentang penggunaan pelataran sehat, akun LMS pelataran sehat yang dikeluarkan oleh Kementerian Kesehatan. Kami adalah lembaga edukasi, lembaga bintang edukasi medika yang akan menjelaskan tentang pelataran sehat, di mana pelataran sehat ini harus diunggah dan juga diisi oleh seluruh peserta untuk mendapatkan sertifikasi dari Kementerian Kesehatan. Bapak Ibu, untuk membuka pelataran sehat, kami persilakan Bapak Ibu untuk masuk ke dalam situs lms.kemkes.go.id. Setelah Anda mengklik lms.kemkes.go.id, Anda akan masuk di dalam tayangan di depan, gitu ya, di depan dari halaman utama. Dan seyogyanya Bapak dan Ibu sudah harus mempunyai email masing-masing yang sudah didaftarkan di dalam login ataupun didaftarkan dan sudah mendapatkan email maupun kata sandi. Ini adalah email maupun kata sandi milik daripada seluruh partisipan ataupun peserta, dan nanti akan mendapatkan kode CAPTCHA, dan kode ini harus Anda masukkan ke dalam kode CAPTCHA dan baru bisa masuk ke dalam akun LMS. Jadi tahap yang pertama membuat akun atau membuat di dalam login akun dulu untuk setiap peserta. Setelah email dan juga kata sandi masuk, baru menggunakan CAPTCHA dan masuk ke dalam akun pelataran sehat atau LMS. Setelah masuk ke dalam akun, Bapak Ibu akan mendapatkan tayangan seperti ini. Nanti kita langsung search untuk pembelajaran. Ya, jadi langsung search ke pembelajaran dan Bapak Ibu akan masuk ke dalam the Third Indonesian Scientific Meeting on Obstetric Anesthetic Critical Care. Setelah Bapak Ibu masuk ke dalam pembelajaran seperti ini sudah akan tertulis berapa jam pelajaran yang harus diikuti, satuan kredit poin yang akan didapatkan, berapa lama video pembelajaran, berapa materi yang sudah Bapak Ibu harus lihat, dan 2 konten yang harus diunduh, serta nanti selesai untuk pembelajaran untuk mendapatkan sertifikat. Setelah Anda mengklik, di situ akan muncul adalah apakah Anda yakin ingin mendaftar pelatihan ini, langsung mengklik iya. Setelah Anda mengklik iya, Bapak Ibu berarti sudah masuk di halaman pelataran yang sudah bisa dimulai. Ya, jadi Anda sudah bisa memulai untuk mengikuti webinar ini dari awal sampai dengan akhir. Setelah itu Bapak Ibu bisa melihat lagi untuk mulai belajar yang akan Anda dapatkan seperti ini dalam pembelajaran. Dan ini yang kalau kita lihat di sebelah kiri ini Anda bisa klik untuk mengetik ya jadi jenis pelatihan ataupun webinar yang Anda sedang ikuti. Pastikan bahwa Anda mengikuti progres belajar ini 100% untuk menyelesaikan pembelajaran. Jadi di akhir daripada webinar ini ada post test yang sudah dibuka panitia maksimal 3 kali 24 jam dan Anda harus mengisi sampai dengan selesai. Post test ini harus diselesaikan setiap peserta supaya bisa mendapatkan sertifikasi dari Kementerian Kesehatan. Bapak Ibu, ada sedikit notes dari Kementerian Kesehatan di mana tadi sudah dijelaskan bahwa pelataran sehat sedang dalam tahap maintenance oleh pusat, maka pembelajaran akun pelataran sehat baru dapat diakses tanggal 12 Mei 2024. Masa pembelajaran di LMS pelataran sehat akan dilihat selama 3 hari sejak kelas webinar di LMS pelataran sehat dibuka. Setelah 3 hari, mohon mengajukan pembatalan pembelajaran untuk kami verifikasi pembatalan secara berkala. Sertifikat baru akan didapatkan kurang lebih waktu 30 hari atau kurang lebih selama 1 bulan setelah kegiatan berlangsung. Baik, demikian penjelasan kami dari pelataran sehat dari LMS. Semoga semua partisipan bisa mengikuti aturan ataupun tahapan untuk mendapatkan sertifikasi dari Kementerian Kesehatan. Terima kasih atas kesempatannya, sukses untuk acaranya. Selamat sore, Assalamualaikum warahmatullahi wabarakatuh. Om Swastiastu, Namo Buddhaya, salam kebajikan dan shalom.
Okay, thank you for the information, Dr. Fahmi. Okay, without further ado, let me introduce the moderator who will lead today's discussion, Dr. Fahmi Agnesa, who completed his anesthesiology and intensive care study from University of Indonesia. Then he continued his subspecialty studies in obstetric anesthesiology. He is currently an anesthesiologist at Permata Hati General Hospital Metro and Sukadanam General Hospital, East Lampung. So let's welcome Dr. Fahmi as our moderator.
Thank you, Doctor, for a nice introduction. Hello, how are you? And welcome, good afternoon, welcome to our webinar series today. In order to go to our ISMOAC in Bali in July, and then today we are very lucky, we have a specific topic with the special speaker today. And I hope you are healthy and happy today. And I go with the first speaker. We have 2 speakers for today, Dr. Kim Osborne from Adelaide and Dr. Colin, residency from Udayana University. And for the first speaker, Dr. Kim Osborne, he is the senior clinical lecturer Adelaide Medical School in University Adelaide. Good city. I have once go last year to the Adelaide, good part, good city. And then she have many, of course, she have many awards and many publication he has made. And please welcome Dr. Kim Osborne. How are you? Dr. Kim, can you hear me?
Yes, I'm okay. Good. So I'm in a park, and the lights have
Yeah,
gone
it's,
off.
I think a good ambience, good park in Adelaide. I very like it. My family very like it, Dr. Kim.
No worries.
Yeah. Okay, Dr. Kim, please, you can presentate now.
Right. Okay. Now just go to. Hold on.
Yeah.
Share.
Dr. Kim,
I'm trying to get.
I want to talk
my-
about the von Willebrand disease in obstetric anesthesia, right?
Yep. Now I'm just trying to. Hold on.
Any problem, Dr. Kim? Maybe
I
the
was just trying to work out sharing the. I'll try this. Desktop. Now is that on your screen? Yes. Is that on your screen? Good.
yeah, cool.
I'll
Right.
let you run it. Okay, at your end.
Yeah, very clear. Okay, you can start.
Okay, so thank you first of all, thank you very much for inviting me to talk on on von Willebrand's disease, which is the most common of the bleeding disorders that we may come across. So just go on to the next slide. So I just thought present a case that you might come across, like a 25-year-old woman who's coming in early labor, and she says she's got a history of von Willebrand's disease. We don't know the type. She's not under the care of a hematologist, but she's had an epidural in her first pregnancy and it's gone fine. So that's just a bit of a case just to get you all thinking about what might be her diagnosis, type of von Willebrand's disease, and give you a bit of framework that we talk about. So just go on to the next slide. So, of course, we have all these diseases that got names, and von Willebrand's disease was the clinical condition was first described by Eric Adolf von Willebrand, and he just described the group of diseases. And, with the genetics, he was able to work out that these patients had a bleeding disorder that, of course, was different from the hemophiliacs, which was a more dominant, it's a different genetic inheritance. But then later on, it wasn't until the late 1950s that they discovered that it was actually a deficiency of the protein in the plasma. And then it was another 14 years later that the protein was characterized and was subsequently called von Willebrand's disease. So just move on to the next slide. So von Willebrand's factor is one of the coagulation factors. We've got 1, 2, 3, 4, and then we've got von Willebrand's factor. So what it does is forms a complex with factor 8, which decreases the excretion of factor 8, which means it lasts longer. Now, how it actually then works with the coagulation is that it mediates the plasma adhesions by binding to collagen and also platelets to form a clot, to help with the formation of the clot. And this is in the laboratory, it's actually enhanced by ristocetin. So that's can be one of the tests that they use. Now, we're talking about obstetrics. And as you all know, there are physiological changes that occur during pregnancy. And as you know, generally, pregnancy is a hypercoagulable state. So generally, most of the clotting factors increase. Although, of course, our hemoglobin decreases, but the coagulation factors increase. And von Willebrand's factor is one of those that goes up by at least 100%, probably often more. And the increase does occur, it starts occurring in the first trimester. So, and you can also see there that I've mentioned about hemoglobin, but of course the platelet count also does decrease, as you all know, during pregnancy. So this does sort of, to a degree, counteract that decrease in platelet count. So we'll just go on to the next slide. Now, some of the material that I've used for the talk comes from a case series which was published 5 years ago, 3 years ago, but it was of a collection of 71 patients over 20 years at the Brigham and Women's Hospital in Boston. That's a very large hospital in Boston, which has got an excellent name in obstetric anesthesia. So even though over that 20 years, they only had 71 patients who had 106 deliveries. Now, in those 106 deliveries, they had an increased PPH rate. And they were about 40% of the patients had a cesarean, and they were able to use neuraxial blocks in about 89%. Now, that may be more than many other places, because I know that the Brigham and Women's are very keen on using neuromuscular blocks. But of course, they're also optimizing their treatment of von Willebrand's disease. So just move on to the next slide. Now, I sort of intimated before that there are various types within von Willebrand's disease. So if people say, oh, they got von Willebrand, it's important to understand, to get a further history of which type it is. Now, the majority of patients who have von Willebrand's disease, fortunately for us, are the type 1. And they just have a partial quantitative deficiency of von Willebrand's factor. So their bleeding propensity is mild to moderate. Then there's type 2, and type 2 can be divided into 2A, 2B, 2M, 2N. And you can see they're all slightly different, but they have a selective qualitative deficiency of von Willebrand's function, and then which decreases the platelet adhesion, and so on. So there's all slightly different. We'll talk about them a bit more later. But then, of course, there's type 3, where there's actually complete quantitative deficiency of von Willebrand's factor. And that one is autosomal recessive, and they have severe bleeding. But the good news about it is the type 3 is relatively rare. So as a group, all the von Willebrand's factors, the incidence is probably about 1 in 1,000. So yeah, so it's about 1 in 1,000, with the type 1 being the most common. Now we'll just go to the next slide. So there are various tests that you need. We talked about the von Willebrand's concentration, and then there's also the density, and also the ratio of the von Willebrand's antigen and its activity with rosetin. Now, you also see this bit about the platelet count. So with 2B, platelet count also decreases. Now, it's also, we'll get onto that a bit more if we go on to the next slide. So let's move on to the next slide. So, of course, the other thing before we go down to each disease, it's important about antenatal planning. So in Australia, the patients with hematological or bleeding disorders, they'd all be managed by a hematologist. And often they've got a database of these patients, especially the haemophiliacs, but sometimes also the von Willebrand, the more severe von Willebrands. So we'd get the hematologists involved early, and they'd then be taking a history and looking at what the past results were and how they may have altered during pregnancy. And it's also important to assess the patient's risk of having a postpartum hemorrhage. You know, they are grand multip, or they're having twins, they had a history of a PPH. So it's important to think about what the other risks of PPH, and then obtain the von Willebrand's panel, which is, you know, the factor and the activity, and also the platelet count. And also to measure those early, but then also near the time of delivery, also check those. Because, as I sort of intimated before, that the pregnancy, the von Willebrand's factor actually increases. So particularly in fact in type 1, it almost be maybe almost normal due to the pregnancy. So that's it. And with the hematology input, important to have a plan, and with the obstetrician, have a plan for how they're going to manage the patient when they come into labour, or have a cesarean section. So we'll just move on to the next slide. So as I said before, type 1 is the most common, and it's a quantitative defect of von Willebrand's factor. And it's generally well compensated during pregnancy. Now, also we've got a target von Willebrand's factor levels of about 50 to 150 international units per deciliter. They're the levels we wanted to get to before we did a neuraxial blockade or before they did a cesarean section. So we'll just move on to the next slide. So if the level's lower than what I've stipulated, you can further increase the von Willebrand's factor by giving them a dose of desmopressin. So in Australia, we tend to, if we're opt to give desmopressin, we tend to give it intravenously at a dose of 3 mites per kilo. And I think we run an infusion, but I think it's over about 10 minutes. And the onset time is 30 to 60 minutes. But remember that the side effects of desmopressin is that it can cause some vasoconstriction. So you just have to, if there's a history of preeclampsia or some other cardiovascular disease, you just need to consider the risk-benefit ratio of using it. Now, the onset's about 30 to 60 minutes, and it does last for several hours. But if the patient's in labour for a long period of time with an epidural, or if they'd had a cesarean and the levels were a bit low, you may want to repeat the desmopressin, but you don't want to give them lots of doses. And you'd also want to be aware that desmopressin can make them peak, and they may actually get hyponatremia. So you just need to monitor for hyponatremia if they get repeated doses. So just have another, move on to the next slide. So once, the other important thing, postpartum, once the baby's been delivered, the von Willebrand's concentrations, which have been increased due to the pregnancy, they can actually drop off. So it's important to, if they've had an epidural in labour, to actually remove the epidural quite quickly after delivery, not leave it in, because the coagulation may then decrease. But I suppose the other thing is just to be wary, to be aware of if they're starting to ooze, if they had a cesarean section, that the von Willebrand's concentrations may decrease postpartum in these patients. Okay, so next slide. So then we're going on to the type 2. So that's probably about 20 or 25% of the patients with von Willebrand's factor. So the 2A is, it can be variable, but it's usually moderate. Now, the type 2B, they're the ones that can be associated with thrombocytopenia, and the TXA, or the desmopressin in particular, doesn't work. You don't want to give that to the 2B. And I discuss it with the hematologist in the 2A, 2M, and 2N. You know, they may think it's okay, but there's a bit of controversy about whether you'd be using desmopressin in 2A, 2M, 2N. But if you need to increase the von Willebrand's factor, you'd be using von Willebrand containing concentrates. So I'm not sure what you've got in your country, but that's what you'd be thinking. And as I've said before, with the 2B, checking out if they haven't got a thrombocytopenia, because they may need a platelet transfusion. Now, just move on to the next slide. Yep. So as I've said, generally ineffective in the 2B, again in function right. And so the other bit is that the desmopressin, why it's bad, is it can sequestrate the platelets and lead to more thrombocytopenia. So that's the reason with the 2B why you don't want to use it, in addition to it not being particularly effective. Okay, now next slide. As I've said, the dose, and the common dose is about, of the von Willebrand concentrate, is 50 international units per kilogram. And you target a von Willebrand's risperidone activity level of 100 units per deciliter after the loading dose. Okay, next slide. Now, the other type is the type 3, which is the rarest subtype, and that's characterized by a severe quantitative defect in von Willebrand's factor, and it's got with little or no production. So there's no response to desmopressin, and so they need von Willebrand factor concentrate for normal coagulation. And so they're actually probably a group that you wouldn't be doing any spinals on. That's for sure. Okay, now I think the next slide, I think that's probably, yeah. So I made it fairly simple, just because I thought it was important to describe the types of von Willebrand's disease, the types, and also remembering the subgroups within two, and also emphasize a bit about multidisciplinary plan assessment and planning for their delivery. The type 1 is we don't tend to, generally we're lucky in that most of those, the level of the activity of the von Willebrand's factor is all just about normal, especially after the desmopressin. So, and they're relatively easy, but there are still some in the type 1 that they might want von Willebrand's concentrate. And then the types 2, and that then with that you would be able to do a spinal for the cesarean section. If they need a cesarean section, you'd be able to use a spinal anesthetic. With the types 2, certainly I think with type 2B, I'd be a bit reticent to put a spinal in, but it also, to me, I mean, if you correct the coagulation, you could possibly, do a spinal, and that's where the Boston group, they had their spinal rates were about 89%. But as I said, they were quite aggressive in doing that. But if you did that, you need to actually have it in consultation and discussion with the patient. So, but definitely, I think also the type 3, I wouldn't be doing any spinals with those. And the other thing is with the types 2 and 3, the von Willebrand's concentrate, as I've said, or fractures, and TXA, you'd be giving them that, but the desmopressin has no effect, and in particular can make 2B worse with the platelet count. So any questions at all?
Okay, thank you, Dr. Kim. Very compact, but with the fruitful and the clear message from you. Maybe for the Q&A session, we wait until the second speaker speak and the case series. Is it okay for you, Dr. Kim?
Yep, that's okay. That's okay. Yep.
Okay. All right. We going to the second speaker. The second speaker is one of the best resident anesthesiologist in Udayana, Dr. Jan Koliniani. He will tell us about the case series in the von Willebrand patient, and I like him motto strive to learn and live with the humbleness. Okay, cool. And maybe you can start the case series, Dr. Colin, please.
Good evening, everybody. I will try to share my slide. Okay, can everybody see?
Wait, Dr. Colin, Dr. Kim Osborne, you have some problem with your visual. Maybe you can take our background to clear the visual, because you have some problem with your visual. Maybe because in the park and in a delay in late night. Okay, please, Dr. Jacob.
Okay. So for the case presentation today, um, the topic is about von Willebrand, and we have given oral desmopressin as an alternative for anesthetic management for von Willebrand disease in patient under going cesarean section in limited settings. This is a case series. First is that von Willebrand itself is a bleeding disorder causing compromised blood clotting, and this is a challenge for everybody, as usually for patients with needing cesarean section will have a lot of bleedings. Also, anesthesia care for this type of patients, especially in rural areas with limited resources, is very complex. Why? Because we have limited resources, and we also cannot do several important tests to diagnose the type of PWD or von Willebrand disease. Also, giving neuraxial can lead to risk of neuraxial hematoma in regional anesthesia. So we still need to do something for the patient. In Indonesia, unfortunately, we don't have the intravenous preparation, but we do have intranasal. But in our place, we don't have also the intranasal. We only have the oral preparation. And so we have given the patients oral desmopressin. Okay, for the first case is a 28 years old woman with 150 centimeters height and weight of around 50 kilogram. She's 37 weeks pregnant with von Willebrand disease, which is known by the medical history of repeated gum bleeding and black stool since 7 years ago. Her obstetric history itself includes prior gestation with one cesarean section in 2020 with postoperative abdominal wall hematoma. And when she came, she doesn't present with any signs of bleeding. For the first case, for the preoperative itself, we prepare her. So we do a interdisciplinary discussion. We do a meeting with all of the staff that are there in the hospital, and then we give tranexamic acid 1000 milligram IV, and then we give desmopressin intranasal 24 hours because the intranasal and IV is not available. Then we give oral desmopressin as a pre-treatment, and we schedule her to undergo a neuraxial block. We also prepare fresh frozen plasma and cryoprecipitate because we don't have von Willebrand factor concentrate. For the patient, the preoperative laboratory testing shows that the factor 8 and von Willebrand factor Ag is very low. And then we gave oral desmopressin for 24 hours, and then we reevaluate the value of factor 8 and von Willebrand factor Ag. It shows increase of factor 8 and von Willebrand Ag in this patient after 24 hours of giving the oral desmopressin. For the first case, we also administer 27 neuraxial anesthesia with 27G quincke needle at L3 and L4, reaching a level T4 blockade with 10 milligram of hyperbaric bupivacaine and fentanyl of 25 microgram. Dexmedetomidine was also given as a sedation agent during the procedure.
and co-administration of 500 milliliter of ringer lactate was given. And after that, we also give around 1,000 milliliter during the procedure, total of 1,500. The total blood loss during the operation itself was 700 milliliter. And intraoperatively, the patient was stable during the operation. Postoperatively, this patient unfortunately have complaint of blood oozing from the operation wound. But after we do an ultrasound in the abdominal wall, we found that there are no intra-abdominal bleeding. And after researching, after we consult with the obstetrician, then they do a researching with local anesthetic, and after that the bleeding was no more. But still, we give fresh frozen plasma for the patient for 3 days, and then we for post-operative analgesic we give paracetamol and opioid, but we don't give NSAIDs. The patient was put in the intermediate ward for observation and then discharged 5 days later. 2 weeks after we follow up by phone, she said there are no complications. The second case is a 37 woman with a height of 161 centimeter. She weighs around 60 kilogram and was 40 weeks pregnant. This patient also had a history of von Willebrand disease known for the last 13 years because she frequently experienced spontaneous bleeding episodes characterized by bruising and bleeding gums. That's why she went to the clinic and then hospitals, and then she became known of having von Willebrand disease. This patient, when she came, she didn't have any signs of bleeding. And then for preoperative laboratory settings, this is emergency case because she have fetal movement. The fetal movement declined, and then it was taken only after 2 hours after giving the desmopressin, because this is an emergent case. So we decided that we can only do we can only spare 2 hours for the desmopressin to work. And then the von Willebrand factor AG and factor 8 itself doesn't really increase that much, but still it increases quite a bit after the oral desmopressin. The case B, we also give tranexamic acid, and then we give premedications with midazolam and meperidine. And intraoperatively, we perform spinal anesthesia using 29G spinal needle with 12.5 milligram of heavy bupivacaine. And intraoperatively, we also give morphine and methyl ergometrin and also oxytocin. Intraoperative hemodynamic was stable. She was also given around 1,500 milli of crystalloid and 179 of cryoprecipitate because the blood loss is around 1,000, and we have not reached the level of factor 8 and POFEG that we want. That's why we also give cryoprecipitate for this patient. Urine output was 900 milli. And then postoperatively, we put the patient in the intermediate care unit with cryoprecipitate for 3 days and oral desmopressin. And then after 5 days of there are no complications of bleeding observed. Also, we follow up 1 week after the discharge, and she shows also no complications. For the third case, as a 20 years old woman with 165 centimeter with weight around 60 kilogram. This one is a 35 weeks pregnant with low implantation of placenta. She notices heavy menstrual bleeding during the menstruation, but she never gets herself examined. And then when she came, she presented with gum bleeding 3 days after the surgery. But when she came, she have no bleeding beforehand. This patient for the preoperative laboratory, because this is also an emergent case, we also gave oral desmopressin and retake the sample in after 2 hours. The factor 8 shows 30 IU per DL and von Willebrand factor of 10. After 2 hours of giving the oral desmopressin, it shows around 30% of 30% increase of von Willebrand factor Ag to 13 IU per DL, but this is still very low and not up to our standard in which is 50 IU per DL. Preoperatively for this patient, we also gave cryoprecipitate because of the increased risk of the bleeding, and then we give midazolam and ketamine, also tranexamic acid, 1000 milligram IV. For the anesthesia itself, she underwent neuraxial anesthesia with 10 milligram of heavy bupivacaine with 27G spinal needle at L3, L4, and oxytocin, ondansetron are given intraoperative. During the procedure itself, the hemodynamic was stable, but after the surgery, we gave only paracetamol and morphine for analgesic. Intraoperative, she was okay, but postoperative, she complained of gum bleeding and epistaxis on the third day. This, so the patient, we gave oral desmopressin continuously for 7 days until 7 days post cesarean session. But on the third day, she complained of mild gum bleeding and epistaxis. So we decided to do a retest of the factor 8 Ag, and we also send resuscitation factor. We also check resuscitation factor and check the ratio, VWF to RCO ratio. After the result was out, then we decided to give cryoprecipitate because we don't have the von Willebrand factor concentrate. And after that, she complained of no more gum bleeding and epistaxis. And then after she was discharged, 2 weeks after, we follow up her with we do a follow up with her, and she shows no complications. For the summary, so 3 female patients, each 20 to 37. All pregnant with von Willebrand disease requiring cesarean sections, was given oral desmopressin due to the unavailability of intranasal intravenous pharmaceutical preparations. All were also given tranexamic acid. 2 of the patients had a positive family history of von Willebrand factor, while cryoprecipitate was also prepared in advance. All patients also underwent regional anesthesia during the procedure. Throughout the surgeries, patients exhibited stable hemodynamics. Postoperatively, 1 patient experienced minor wound bleeding, which ceased after resuturing under local anesthesia. And another patient reported gum bleeding and epistaxis, which were successfully managed with cryoprecipitate administration. All patients received paracetamol and opioid for postoperative, but we gave no NSAIDs. This might be the summary for the pre and post laboratory testing that we have done. And so cesarean sections once again carry risk of bleeding and complications. In women with von Willebrand disease, this risk is amplified because of the impaired clotting mechanism. And so because of this, we need a very meticulous planning and management because what we gave was not a uh, standard therapy. We have to be very finicky about what we give. We have to be very careful about what we do for the patient. Maybe so this case series shows that oral desmopressin in the absence of intravenous or nasal desmopressin might be an option. But a multidisciplinary approach with the surgical team is the essential part to address the potential bleeding complications. Proper hemostasis during the surgery and availability of blood products and clotting factor replacements are very crucial. In cases of von Willebrand factor and factor VIII concentrate that are unavailable, cryoprecipitate containing both factors can be prepared and administered. From this case series, we can also see that neuroaxial anesthesia is generally considered safe for pregnant patients with type 1 von Willebrand disease. Maybe that's what I can present. Thank you so much.
Okay, all right, cool. Thank you for sharing your patient with us, Dr. Colin. It's time to our discussion, Dr. Kim and Dr. Colin. Maybe some question is direct to me, but some question. Dr. Kim, we know that the pregnant woman in atrium is hypercoagulable state, and you say that von Willebrand factor 8 and many factor is increased 100%, is about 2 times. And what about cutoff of von Willebrand factor that we can do the spinal or epidural anesthesia in your practice, Dr. Kim? Dr. Kim, your mic.
Yeah.
Yeah.
I think generally with the type 1s, especially where you've given the desmopressin, then you've checked it, I think they're the ones that you're able to do the spinal anesthetics. I think that you've illustrated that quite well.
Yeah.
I think that's exactly right. One of the tricks is, of course, is the postpartum, as it's been described, then the coagulation drops off a bit. So that's a tricky bit, isn't it? And giving it oral desmopressin probably takes longer to act than IV, which takes 30 to 60 minutes. But I thought it was really good that you then used cryoprecipitate to correct it when they were bleeding afterwards. Oh, now I'm just saying, I'm in the park and my computer might go, the battery power is low. So I may, if no offense, if I suddenly go poof, it's because the battery's gone.
Yeah. Okay. And what about in your practice? What about the thrombocyte count cutoff, the lowest level? Do you do the neuraxial?
Well, it'd probably be the 50.
50.
Yeah.
You decrease the cutoff from the non-pregnant woman?
The amount in the non-pregnant woman, I mean,
can we decrease the estimation, the cutoff? Because we know that in the pregnant woman is hypercoagulable, the thrombocyte maybe in the atrium is decreased, but the quality of the thrombocyte is quite good enough.
Yeah, I
And
know what you mean. I was just, I did a bit of a review of the literature, and my understanding was that it's 50 is
yeah,
what, I mean, some centers you can have it a bit higher, but I
yeah.
think we typically use 50.
Okay. 50. Do you have any opinion, Dr. Colin, for the, because in your presentation, in the second patient is quite low, the level of the von Wilburn, and then another patient is quite low, because just I know is the about the 50 EU international unit for we do the spinal anesthesia. Do you have any opinion, Dr. Colin? Your mic?
Okay. Can you hear me?
Yeah.
Okay. So from what we have discussed before the surgery for this patient is that first is that we are quite sure that the quality of the von Willebrand factor, because this is a type 1,
Yeah.
we are sure that this is a type 1, most likely to be a type 1 von Willebrand disease.
Yeah.
And so it will be only a quantitative
Deficiency, right?
deficiency. This is why first we give oral desmopressin, and after 2 hours of giving the oral desmopressin, the repeat test, we actually we don't yet know the test result, because we need to
Yeah.
send it, we need to send it. But from what we can see is that because first we are sure that this is type 1, and then the platelet is still good, the platelet is still above 100,000.
Yeah.
And also the other coagulating there are no prolongation of ENR, which means
It's
at
good
that
quality.
time, we thought that it will be quite safe, though we are not very sure
Yeah.
about it. But for type 1 literature that we have read, it is quite safe to do a neuralgia for type 1 patient.
Oh,
That is why we still decided to do neuraxial anesthesia for this patient.
okay. And you use
Maybe
the smallest needle, 29 Winkle needle for the
the smallest
second
needle
patient, right?
that we have.
Yeah.
Yeah, we also use the smallest needle for the patients. We also use the dose and hello.
All right. All right. And we continue with the second question. It's about do you have any advice, Dr. Kim Osborne, to do the spinal anesthesia in category 1, let's say in a fetal distress? We cannot check the laboratorium for coagulopathy or thrombocyte, and we must do the do you have any advice to do the smooth or anything to do spinal? Yeah, please,
So
Dr. Kim.
is that in relation to this, one of the patients with von Willebrand's disease?
Yeah, von Wilburn or anything else with the thrombocytopenia. Maybe you
Yeah.
can any advice to do some neuraxial?
Well, probably. I mean, if you haven't had time for the desmopressin to work, and I mean, it also would depend on what their history is. But I would probably, unless I knew what it was, the level, and I'm pretty conservative, so I would probably tend to give them a GA if I wasn't sure what was going on. I mean, unless they had mild mild type 1, because there is a bit of variation with it. And if you haven't had time for the desmopressin to work, I'd be in a Cat 1 situation. I'd be probably doing a GA, because when you're using those small needles, those you're describing, you're also doing it very gently as well. Which you may not, when it's a Cat 1, you mightn't have time to be quite as gentle as you would have in an elective patient, with von Willebrand's disease. So, just the nuances there as well. But it's always a risk benefit as well. But I would probably be erring for the GA. But also, you may then, once the surgery is progressing, because you may need to have the cryoprecipitate. But that'd take a while for the cryoprecipitate to get from the lab, to be thawed, etc.
Okay, I go to the Dr. Colin. It's about we didn't have any IV solution for desmopressin. Do you know about the preparation? How many milligrams desmopressin is, and can we get the oral before the operation on suspect the von Willebrand disease for our patient?
Okay. So for these cases, fortunately, we have the history of the patients, and she came with doc. I have a deficiency in von Willebrand, and directly after that she have von Willebrand disease, then you directly start the desmopressin, because oral takes around 6 to 7 hours to pick. So for the preparation itself, we have 200 micrograms, which is for around 50 kilogram patients is around 0.4 microgram per kilogram, which is, I think, quite enough for patients in Indonesia, which have usually around 50 to 60 kilogram of patients, because like what Dr. Kim has said, that the dose is 0.4. But what we have done is that we repeat the doses 4 times a day. That's what we have done.
How many tablets do you give your patient?
One tablet,
One tablet,
but 4 times a day.
0.1 milligrams.
0.2.
0.2, okay.
0.2 4 times a day. But this may causes, like what Dr. Kim has said, it causes risk of hyponatremia. So we need to be very careful about it. Maybe that's
okay. Hyponatremia and retention water, right?
Yes.
Okay, we go to Dr. Kim. It's about the specific component. Do you have any specific component in Australia for von Willebrand factor?
I'm just trying to remember. I'd have to. Look, I'm sorry. I'm not sure. I'm not certain. I'll tell you next week. But I do know that the desmopressin's 4 units per mil, the IV solution. Just hold on a sec. Von Willebrand's von.
What about you use the precipitate FEV for the deficiency factor in the pregnant woman? What about using the whole blood to increase the von Willebrand factor? Because many places in Indonesia we didn't have any specific blood component. Do you any idea about that?
Yeah, in Australia we don't use whole blood.
Yeah,
We use just component.
blood.
We just have the yeah, we just and we do use hold on.
Cryo and FFU, right?
Yeah, we're some country in parts of Australia they do use fibrinogen. They do use fibrinogen concentrate. That's a different.
Okay.
That's a different. You know, for obstetric hemorrhage, but that's a different. That's a
Yeah.
different thing.
Yeah, but it's interesting because we know that the von Wilburn and the fact eight factor like Titanic, Kate Winslet and Leonardo DiCaprio, you jump I jump, they decrease in the von Wilburn, decrease in the eight factor, and we know that the eight factor is intrinsic pathway. What about we compensate the increase the extrinsic pathway and common pathway like fibrinogen or factors 7 factor to maintain the coagulation in the von Wilburn patient? Do you have any idea or theory about that?
Yeah, I mean, what I do know is that it's really, not in von Willebrand's disease, but generally in PPH.
Yeah.
It's the fibrinogen, which is really the key in replacing.
Yeah.
That's really the key. But I haven't really got any. That's always the one that is a lot. Functionally, you need to have a higher level, and that's the one that's really important to replace. Now, I just checked. In Australia we have, it's called biostate, and it's a concentration of human. It's factor 8 and
Okay.
von Willebrand's factor. So
Okay.
that's what they use. They use biostate, which is
Yeah.
a combination of human factor 8 and von Willebrand's factor. So
Okay.
that's what we do have in Australia.
Okay. Do you have any opinion, Dr. John Colin? Maybe for the site of action of desmopressin, because we know the type 1 is about the partial quantity. Type 2 is about quality deficiency. Type 3 is about total deficiency. In the type 1, we can use desmopressin, but it's not in the type 2 and the type 3. Do you have any side action or desmopressin we give the oral with the patient?
Okay. Maybe what I can say is that the site of action is with the IV preparation, it's all the same.
Yeah.
But what we need to see is the increase. What we need to know is the increase of the von Willebrand factor after we give the desmopressin. Like in these cases, what we have done is before because of the patient having very low level of von Willebrand factor, we directly give cryoprecipitate for the patient. For an emergent case, we give it even for the before the surgery begin. So we do a pre-treatment with cryoprecipitate. Prepare as soon as possible for the cryoprecipitate because we cannot sometimes because we are very limited in resources. We
Yeah.
don't have we cannot do multiple examinations of von Willebrand factor
Yeah.
intensively, like for after 4 hours. Usually the guideline says after 4 hours we need to do a repeat test, and but we cannot do it like that here, and that is why like what I said, we need to be very finicky about it, and so we need to check what we can do and do what we can. Maybe that's what I can say.
Okay, correct me if I wrong. The desmopressin site action is because in endothel receptor for vasopressin, right? Does that have a side effect like the retention of the water? Is that correct, Dr. Colin?
Yes, Doc.
Yeah, in
Correct.
endothel. Okay. And Dr. Kim, I know in Adelaide, because I go over there, you have many resources to do the check coagulation, like using the ROTAM or TEG, thromboelastogram. Can we use the ROTAM or thromboelastogram to diagnose the deficiency of the von Willebrand? Oh, sorry. Dr. Kim. Okay, maybe his laptop is the battery is finished. Okay, we next to and wait until he charged the battery. Dr. Colin, can you give us the maybe advice suggestion about how can we um, know the type of the decrease of von Willebrand, type 1, type 2, and type 3?
Okay.
To know the from the laboratorium.
Mhm. Okay. For maybe what I can say is that
A case series never can never be a recommendation, but what we can say is that for diagnosing von Willebrand disease type 1, like what Kim has shown us, is that first is that uh, it is not a qualitative decrease, it is a quantitative decrease. So we can see that the level of von Willebrand factor is will be very low. And then we can also see that the symptoms for the patients is generally mild. That from that case, then we can usually
it's not 100%. We can usually know that the patient is a type 1 von Willebrand disease. Maybe that's from clinical that's from the clinical perspective. Maybe
Yeah,
can you,
correct.
maybe Dr. Kim can add more.
Yeah, wait till Dr. Kim come. Yeah, I agree with you because we know the three types. The first one is we can check the like you check in your laboratorium with the deficiency factor von Willebrand factor AG antigen decrease in 30 maybe with the some spontaneous bleeding. And because in 30 and 50 it's maybe normal in a pregnant woman, because we know from the Dr. Kim slide, in woman patient for women decreased 2 times. And then for the of course for the type 3 is very low for the factor 7 factor antigen. And for the type 2, maybe the ratio of the factor 7 and the factor resocytin cofactor is below to the 0.7 level, and we can make sure that the type 2 von Willebrand deficiency factor. Okay. And in all your patient, you give the tranexamic acid for the patient. Can you tell us what the site of action of tranexamic acid, and then what we caution about the using tranexamic acid for the pregnant woman? Do you know that?
Okay, maybe for the tranexamic acid, uh, it reduces bleedings before, during, and after the surgery, because it inhibits the breakdown of blood clots, and so it is also an adjuvant therapy in the guideline for von Willebrand disease. That is why we have given all of our patients tranexamic acid. Maybe that can answer the.
Okay. And apa yang kita harus ini, Dok, dari asam tranexamat kalau untuk wanita hamil, dan cara pemberiannya mungkin supaya penonton juga dapat message-nya dari pembicaraan kita juga, salah satunya dari asam tranexamat ini. Jadi kalau asam tranexamat yang kalau kita ketahui bahwa dia kan berarti dia anti dari inhibit terjadinya fibrinolisis. Dan kita tahu bahwa ibu hamil itu ada yang namanya triad virtue, di mana hypercoagulable, statik, kemudiannya adanya trauma pada saat plasenta lahir, itu resiko terjadinya tromboemboli akan lebih besar pada wanita hamil itu 5 kali, bahkan pada saat kelahiran itu bisa 60 kali. Dan itu sebabnya penggunaan asam tranexamat harus tepat guna juga untuk seperti kasus ini, mungkin tepat untuk mencegah terjadinya pemecahan dari fibrinogen gitu ya. Jadi dia dapat jadi mencegah jadi pendarahan. Tapi hati-hati pada saat dia kondisi misalnya PEB atau pasiennya gemuk, kemudian ada risiko tromboemboli dan sebagainya, itu bisa kita menjadi harus lebih hati-hati untuk itu. Oke, karena juga waktunya juga cukup sudah selesai. Terima kasih atas perhatiannya dan diskusinya juga. Kita dapat beberapa poin di mana bahwa von Willebrand ini walaupun jarang, tetapi ternyata 80% itu type 1, jadi nggak perlu khawatir. Dan kita juga bisa lebih menurunkan kadar jumlah trombositnya dan sebagainya, karena memang pada ibu hamil itu rata-rata seperti faktor 7, 8, 9, kemudian faktor 10, 12 itu naik semua. Yang turun hanya faktor 11 sama 13. Jadi kita juga dengan adanya secara fisiologis hypercoagulable tadi, kita juga bisa menentukan bahwa type 2 yang 80% itu cukup aman. Apalagi kalau kita punya desmopresin yang bekerja di vasopresin di endotelnya sehingga menghambat, sehingga faktor-faktor seperti faktor 8 dan faktor von Willebrand juga meningkat. Jadi kita bisa melakukan neuraksial. Tadi juga pesannya juga baik sekali dari Dr. Kim juga. Nah, kita juga bisa melakukan dengan gentle, dan untungnya di Australia mempunyai obat-obatan yang langsung direct untuk yang von Willebrand dan faktor 8 gitu. Tapi tidak menutup kemungkinan teman-teman yang di daerah apabila tidak mempunyai whole blood itu juga tetap ada walaupun sedikit komponen dari faktor pembukuannya. Kalau mempunyai FEV dan sebagainya mungkin itu akan lebih baik lagi untuk meningkatkan faktor pembukuannya. Mungkin itu yang bisa kami sampaikan. Terima kasih Dr. Colin, terima kasih. Thank you for Dr. Kim. Maybe because the battery laptop from Dr. Kim. Kita akhiri presentasi atau pertemuan kali ini. Terima kasih teman-teman semuanya. Saya kembalikan ke moderator. Terima kasih.
Terima kasih banyak.
Well, finally, we have come to the end of this webinar series event. On behalf of the entire committee, allow me to express our gratitude to Dr. Fahmi as the moderator, Dr. Kim Osborne as our speaker, and Dr. Kanjan Kolenjani for taking the time to share their knowledge. And also to our sponsor, PT FIMA International and PT Active Scientific for their support. And to all of the participants who have attended and participated in this guest lecture. We apologize if there is still shortcoming in the implementation of this guest lecture and would like to invite our participants to attend the next webinar series, which we have online on 24 May 2024. The link for the next webinar series, I would like to inform that the attendance can be accessed through the link, which can already available in the description column. Of course, we hope this event can provide valuable knowledge and insight for all of us. See you at the next webinar, and allow me to close this guest lecture with Parami Santi. Om Santi, Santi, Santi Om.